For decades, millions of healthy adults swallowed one of these every morning. At 19 cents a bottle, it was treated as a harmless daily vitamin to ward off heart attacks. Healthy people adopted this routine by the millions. Because the pills were cheap, sold over the counter, and heavily promoted, the public assumed the protective benefits applied to everyone, largely ignoring the drug's intense biological potency. Then, the medical consensus shifted. In recent years, institutions like the American Heart Association and the U.S. Preventive Services Task Force issued guidelines actively advising healthy older adults against starting a daily aspirin regimen. Yet for patients who have suffered a heart attack or had a coronary stent placed, the directive remains as strict as ever. Take your daily low-dose pill and do not stop. The chemical makeup of the drug never changed. What changed was the medical community's understanding of statistics. The math of blood clotting applies entirely differently depending on a patient's baseline risk. We have to look inside the bloodstream. Normally, platelets flow freely through healthy arteries, ready to clump and seal any vessel damage. Aspirin executes a pharmacological hit-and-run. Within 20 minutes, it binds to a specific enzyme channel inside the platelets, COX-1, permanently blocking clotting. Because platelets lack a cell nucleus, they cannot synthesize new protein to repair this. This interaction irreversibly disables the cell for its entire lifespan. This exact mechanism stops deadly arterial clots from forming at the sites of ruptured plaque, but it equally impairs normal hemostasis, leaving the body vulnerable to gastrointestinal hemorrhages and bleeding in the brain. The drug cannot distinguish between preventing a fatal stroke and causing a dangerous ulcer. Because this cellular action is blind, its medical value relies completely on the patient's existing mathematical probability of suffering a deadly clot. Cardiologists divide patients into two groups. The first is secondary prevention, individuals with a history of cardiovascular disease and a high risk of recurrent clots. For high-risk patients, reducing heart attacks produces a massive clinical benefit that clearly outweighs the bleeding hazard. But the math changes for healthy individuals. Their baseline clot risk is incredibly low, shrinking the potential benefit to a fraction of its former size. Large-scale modern trials, like the ASCEND study, confirmed this reality. In healthy populations, the absolute number of vascular events prevented by aspirin is almost perfectly matched by the absolute increase in major bleeding. Taking a higher dose, like 325 milligrams, fails to improve this equation. A standard 81 milligram dose already achieves near-complete platelet inhibition. Pushing the dose higher simply erodes the blood vessel's natural protective properties without adding cardiovascular defense. For healthy adults, a daily aspirin acts as a statistical zero-sum game, where the benefits and harms directly offset each other. This narrow margin of benefit has shrunk even further in recent decades. Widespread use of statins, smoking cessation, and strict blood pressure control reliably reduce the risk of heart attacks without introducing any bleeding hazard at all. This leaves modern cardiologists with a highly specific challenge, identifying the extremely narrow subset of healthy adults, typically between the ages of 40 and 59, who have enough hidden risk to justify the drug. To find them, doctors increasingly rely on a diagnostic tiebreaker, the coronary artery calcium score. By putting a patient through an advanced CT scan, they can look directly for subclinical plaque building up inside the arteries. A calcium score of 0 confirms the patient is at extremely low risk for ischemic events, meaning the bleeding hazard of aspirin dominates. But a score over 100 reveals a physical plaque burden that might make the risk of a microbleed worth taking. Blanket preventative prescriptions have been permanently replaced by precision imaging and individualized modeled calculations. The modern evidence leaves two absolute rules. If you have a prior history of heart attacks, strokes, or coronary stents, the benefit is undeniable, and you should never stop a daily regimen without explicit medical authorization. Conversely, if you are over 60 and otherwise healthy, initiating a daily aspirin introduces an unacceptable risk of internal hemorrhage with no net protective benefit. Acetyl salicylic acid permanently alters your blood cells for their entire lifespan. It is a potent, irreversible biological intervention. Adding it to a healthy routine without precision medical guidance is no longer a safety measure. It is a statistical gamble where the house usually wins.